Ocular Demodex. I'll be discussing a few facts about this arthropod named as Demodex, which is a quite common yet underdiagnosed cause for blepharitis. Demodex folliculorum and Demodex brevis are two mites which infest the human eye and which may, in excess, lead to a wide range of anterior segment findings. Both mites in their adult form are cigar-shaped with four pairs of legs to grip the cylindrical structures such as an eyelash. Demodex folliculorum, which is relatively larger in size, around 0.3 to 0.4 mm, it tends to inhabitate the base of the eyelashes and cause anterior blepharitis. Whereas Demodex brevis, which is smaller in size, around 0.2 to 0.3 mm, it preferentially inhabitates the sebaceous glands and predisposes to meibomian gland disease. The life cycle starts as an ovum. After around 3 to 4 days, the six-legged larva is hatched out of it. Then it grows into adult form in next 7 days. The mites take approximately 2 weeks to mature from the egg to the larval stage with an overall lifespan of up to 3 weeks. Now coming to pathogenesis, since folliculorum inhabitates the base of eyelash follicle, it feeds on the follicular and glandular epithelial cells, causing direct mechanical damage so that it can lay their eggs over there and also results in follicular distension and misdirection of lashes. Also, excretory organs are absent, due to which the undigested material is regurgitated and combines with these epithelial cells, keratin and eggs to form the bulk of cylindrical lash deposits, which is pathognomic of Demodex infestation. Demodex brevis has a predisposition towards the meibomian gland where it causes a primary mechanical blockage of the orifice. Accumulation of parasite excreta causes blockage and may also elicit a cell-mediated reaction. The chitinous exoskeleton acts as a foreign body, causing a localized granulomatous reaction. This granuloma may develop into a hordeolum or a chalazion. Now discussing about a case of a 23-year-old male patient who presented to our OPD with complaints of redness, itching and burning sensation in both eyes since 2 to 3 months. He has been using all sorts of treatments including hot compressions, antibiotic ointments, steroid ointments, lubricants, etc. but not relieved. On examination, the visual acuity was 6 by 6 in both eyes. Intraocular pressure was 10 mm of mercury in both eyes. On slit lamp examination, there was fine waxy debris concentrated at the base of eyelash. Hyperemia and collarettes at the eyelid margins, papillae in the conjunctiva. Rest anterior segment was normal. To confirm my diagnosis, I went to microbiological lab and took some glass slides, cover slips, a normal saline bottle, and an epilation forceps. I took out a few cylindrical lashes and kept them over the glass slide. I poured a few drops of saline over those and covered with a cover slip. Then I put the slide under a light microscope. At first, at 4x magnification, I saw a mite trying to hide behind the lash. Then I increased the magnification to 10x and then to 40x. The mite was actually dancing in front of my eyes, or at least I imagined it to be. I was able to appreciate the movement of the mite. So I realized that the diagnosis for ocular demodex is mainly clinical with microbiological confirmation. It is based on signs rather than symptoms. The common symptoms include itching, burning sensation, foreign body sensation, watering, blurring of vision, ocular discomfort, and irritation. The common signs for Demodex folliculorum include cylindrical dandruff, which will present as fine, waxy, dry debris concentrated at the base of the lash, which may lead to trichiasis, dystichiasis, mydrosis, and erythema of the eyelid margin, and other eyelash disorders. While Demodex brevis, which has a predisposition for meibomian gland disease, it may manifest as hordeola, chalasia, blepharoconjunctivitis, or blepharokeratitis. So now how to manage it? I discussed with my consultants and colleagues and came to a conclusion that the primary goals for management of this parasitic infestation is to reduce the parasitic overpopulation in the lids and lashes and to decrease inflammation. Also to provide a healthier environment for the ocular surface. The recently approved regime for Demodex ocular infestation is tea tree oil. Terpenin 4-ol or terpene is the active ingredient. It has antimicrobial, antifungal, antiviral, antiseptic, and acarcidal properties. This leads the mite to exit the hair follicle and migrate onto the skin before mating. It can be used as an office-based or a home-based regime. In office-based regime, around 50% concentration of tea tree oil is used. The goal is to stimulate the mite's migration out of the lash follicle. In home-based regime, the patient is instructed to clean the lids and lashes as well as smear the lid cleanser onto the eyelash roots of both upper and lower lid margins. Complete coverage of the eyelash base by the tea tree oil lid cleanser is necessary to be effective so that the mites are unable to lay eggs and hatch more Demodex mites. Patients should be instructed to use the wipes on their eyelash, forehead, eyebrows, and cheeks as the mite live in all of those areas. The duration of treatment should be for at least 6 weeks, which will cover 2 life cycles of Demodex to ensure complete eradication. To conclude, ocular Demodex is a common but underdiagnosed condition. Early diagnosis and treatment will help to prevent the patient from the discomfort and also from undergoing various experiments for treatment. There has to be a high index of suspicion when a patient walks into your OPD with these sort of complaints. The goal is to reduce the overgrowth and alleviate the clinical signs and improve patient symptoms. Thank you.